We're the end of the day, but we're talking about our favorite things, which is women's health. So, yay! Um, I know we are introducing ourselves. I am not good about introducing myself with titles, etc. So I thought I'd tell a little bit of my story because it's a little bit different than probably a lot of you. So I am an OBGYN. I started my residence, or I did my residency in Philadelphia at Jefferson, where we were at the time the only hospital that was doing methadone stabilization for pregnant people. And we did that relatively quickly inpatient. We do not call it induction because that means something else to us. Um, so we did that like daily. We did that all the time. That was bread and butter for us. And then I came up to the Bay State as an attending, and we really didn't have much. And so I sort of took the helm at Bay State, made guidelines. I now have a clinic for pregnant people with substance use disorders. I got my BUP waiver and I'm prescribing for my patients. And then I did go through the practice pathway and got addiction board certified. Woo! So hopefully that gets, continued. And so if you hear me talk, I'm a lot of times going to be talking about pregnancy, but today, I run the gamut in terms of what I practice. And so today we're going to be talking more about sort of the lifespan of reproductive health. And I'm really excited.
So I'm Matt Rogalski, and I am similarly weird in that I was practicing OBGYN for a total of 12 years, did my residency at Hahnemann, God rest its soul. I was practicing for 12 years, but was inspired to start helping with opioid use disorder and addiction medicine topics during my practice of OBGYN, and did kind of an iterative step over in that I directed an OTP for 3 years while I was also practicing OBGYN, and then fully stepped all the way over about 3.5 years ago. So kind of a different journey, but I'm here, and that's kind of the background that I have to be able to talk to you guys about women's health today too.
Okay. And so these are some objectives for today to talk about the barriers to effective contraception use in this population. We want to talk about person-centered model for family planning counseling, and also we're going to talk about contraception and family planning options for these patients and how you all can potentially incorporate this into what you do every day. So starting with a quote, reproductive freedom is critical to a whole range of issues. If we can't take charge of this most personal aspect of our lives, we can't take care of anything. It should be seen as a privilege or as it should not be seen as a privilege or a benefit, but as a fundamental human right. So I want to start with a case. This is one of my patients, and of course I'm practicing largely high risk obstetrics, so a lot of my patients are pregnant, but often it comes up in the first visit. How are we having a safe inter-pregnancy interval? What are you planning for contraception afterwards? And is always part of pregnancy care. And I chose this one because I think it highlights a lot of what we're going to talk about throughout the program. So this is a 37-year-old. Sorry, this is our language. G3P2. It means she has 2 children at home. She is currently pregnant at 19 weeks. She came for her new OB visit with me. She had opioid use disorder, not on meds, so actively using fentanyl. And she had actually a initial visit when she found out she was pregnant with a different provider. Because she had children at home and she disclosed her drug use, a 51A was filed, and so now DCF was in her life. Because of that, she no longer wanted to see that provider or that office at all for care. She was very ambivalent about the pregnancy for several reasons, partially because of the 51A, and she also described thoughts that her drug use would cause the baby to be malformed and dirty. She went to Planned Parenthood twice, intending to get a termination, but wasn't able to go into the building. And she actually called my office from the Planned Parenthood parking lot, just like distraught. She wanted to make sure the baby didn't have any malformations before she decided to continue the pregnancy. So we actually were able to get her in same day. She got an anatomy ultrasound and also had a visit with me that included options counseling, how she wanted to proceed with this pregnancy. She had not a ton of medical conditions, tobacco use, depression, anxiety. And through the course of our pregnancy, we had sort of the opioid use disorder course was waxing and waning as they often are. She initially wanted to detox naltrexone, then ultimately stabilized on 8 milligrams of butid. She did relapse during the pregnancy. And I honestly think methadone probably would have been better for her, but we're talking about all these barriers. She just felt she couldn't get to a clinic every day. And then ultimately she went to residential treatment program postpartum. She delivered via a C-section and was luckily able to go to the residential recovery program with her newborn. We did a lot of contraception counseling postpartum, and because I was a repeat provider, it was nice because I saw her a lot postpartum, so we got to do a lot of talking. She definitely didn't want a repeat pregnancy, and she specified she didn't want one while she was on MOUD. Her concerns about contraception was that she did not want to gain weight. She felt that would be a trigger for her to relapse, and she also didn't want implants in her body. So that meant that she declined Depo-Provera and IUDs and Explanon. She had a contraindication to combined hormonal contraceptives, which was being a smoker at age 35. And she declined sterilization at the time of her repeat C-section because she didn't want a pregnancy anytime soon, but she wanted to have that option. So the remaining options were her condoms and progesterone-only pills, and what she ended up deciding on was condoms and natural family planning. And so while we go through this, I hope you'll sort of come back to this case because I think it highlights a lot about what we're going to talk about. Unplanned pregnancy and the anxiety that surrounds this situation in patients with OUD, the stigma patients feel when they become pregnant or even want to become pregnant with OUD, options counseling and the importance of a non-stigmatizing environment for this, and also the complexities of contraception counseling in this population, and that the final plan won't always be what the provider feels is best. So unintended pregnancy rates are higher in people of reproductive capacity with OUD than in the general population. About 45% of pregnancies in the general population are considered unintended. That does not mean undesired, just they were not intending to get pregnant. And up to 86% of pregnant people with opioid use disorder report an unintended pregnancy in their lifetime, with one study showing up to 8 in 10 pregnancies among opioid using women are unplanned. 54% of women with SUD report 4 or more pregnancies compared to 14% in a nationally representative sample. And the majority of patients report wanting to prevent or delay pregnancy in this population, but very few utilize highly effective contraception. This population also has a higher rate of pregnancy ambivalence, so not being quite sure if they want to get pregnant at all, and if they get pregnant, whether they want to keep it. So it's a really nuanced situation.
So, everybody, we're going to do a very informal poll. How many people have had patients or clients in their OTP or OBAP tell them that they do not get periods? It's about 80%. How many say they get very irregular periods? Probably about the same. How many of us ask about a patient's last menstrual period during their intake into treatment? It's about 40%. How many ask about the number of pregnancies and deliveries, the G's and P's that Megan was going through? That's pretty good. That's about 30%. Okay. So one thing that I wanted to start with was to talk about some of the applicable CNS effects of opioids. The fact that there is direct action in the hypothalamus, it reduces GnRH secretion. If anybody is triggered by all the physiology I'm about to go through, I'm sorry. So that's the first place here is your GnRH production from hypothalamus to pituitary gland to get your further downstream hormone production. That will directly decrease the amount of luteinizing hormone and follicle stimulating hormone that you produce. That will then reduce the gonadal hormone production, most especially estradiol. Testosterone is what we obviously all see with our male patients who are not included in this talk today for obvious reasons. The anterior pituitary prolactin production is also increased by opioids. And there will be a slide coming in where I can show you what a difference that makes. So you get less dopamine production by the hypothalamus. The prolactin will further suppress the follicle stimulating hormone here that will help with development of the follicles that would ovulate. The other thing here that's important is endogenous beta endorphin is decreased by opioid use. So in addition to all of the other things that the exogenous opioids are doing, it's decreasing your body's ability to produce its own endogenous opioids, which has impacts all over the place. So now when we go back and we think about what the opioids are doing endocrine-wise, so here we are with decreased LH and FSH production. Again, if anybody is scared by this graph right here from medical school or from residency, I'm sorry. But this is the typical cascade and sequence that occurs when you are developing this follicle, ovulating it, and then in the luteal phase when you're supporting that follicle. So the important things for that are that there is a follicle stimulating hormone rise sort of right around and through the time that the woman's menstruating. And then there's just kind of like a tonic secretion that is elevated. So that's important to stimulate this follicle in the ovary that's going to be the primary one to develop. This rise in estrogen, which again can get messed with by opioid use, also helps to drive that production. The key for the ovulation is this surge in luteinizing hormone as well as FSH, but it's really luteinizing hormone that ends up causing the ovulation of that follicle. So all of those things together can lead to the fact that you will not have this process go regularly and you will end up with oligomenorrhea, which means reduced menstrual periods, or amenorrhea. No. So again, some of the targets here are, I did have some little thingies on here. You're talking initially here about the gonadotropin independent phase. This is really where estrogen can start to come in initially as it's rising. You have your phase where the FSH comes in and does a lot of the maturation on the cellular level here. And then obviously LH coming in. So the summary of this really is that the physiologic changes that happen as a result of active opioid use, and this is any and all opioids, by the way, this really has an impact on the function of somebody's menstrual cycle. So we can go back to 1969, and Dr. Wallach had a study where the methadone maintenance treatment program, where they took a look at people that were narcotics addicts. Again, the language is awful, but it's 1969. They recognized even then that those patients had amenorrhea and ovulation, or oligomenorrhea in different ways, and they were infertile. They gave 95 of these women methadone. The ones that were premenopausal, all but one resumed regular menstruation. So a pretty good proof of concept that treatment of the opioid use disorder and some degree of, we'll call it regulation, stabilization, normalization of the opioid levels was able to restore menstrual function. So these are some other very pertinent fertility facts that I wanted to highlight because it actually matters quite a bit for what we're doing here. So this is a great word, fecundability. That's the probability of achieving a pregnancy in a single menstrual cycle, adequate sperm exposure, no contraception, results in a live birth. So that's 30% for one cycle. And that happens in the first 2 cycles. When you add that cumulatively over the course of 12 months of unprotected intercourse, you have an 85% chance of getting pregnant if there is no block in the way, 12 months of unprotected intercourse, okay? The fertile period, 5 days before ovulation and on the day of ovulation, those are kind of the best times that you could do it. But in ovulation and ovulation outside of the expected time definitely does happen, and happens more often with some other medical conditions. Sperm live in the reproductive tract for 2 to 4 days. And then postpartum ovulation is resumed at 45 to 94 days after birth, with the earliest being at 25 to 27 days. Why would I talk about that? This is the marker for what we all see which is that you can ovulate before your first menstrual cycle. So before the first time that this woman has a menstrual cycle to say, oop, I could get pregnant again, they ovulate once. So that is one of the more important things to keep in mind when we're talking about women's health. We're talking about prevention of unplanned pregnancies. It's not just something that we have to think about at a certain time. It's all the time. It's a dice roll every month. So it's just something I'm using to really help to sort of frame and propel as we continue to talk further about planning.
All right. So gonna move forward and talk about reproductive health, reproductive care, and contraception care. And this population has significant barriers to reproductive care. And we just heard about one of them, which is that a lot of these women that come in, particularly with active drug use, think that they're infertile or not able to get pregnant, largely because they have oligo or amenorrhea. And on top of that, they also are concerned about affecting future fertility. So, can I never get pregnant? And so, starting something like contraceptive sometimes feels adverse to that goal of potentially a future pregnancy. There's been several qualitative studies that look at the reasons how patients with OUD decide what type of contraception is right for them. And some of the reasons are things that, the average GYN or reproductive provider might not even think about. In these studies, patients report placing significant value in maintaining their recovery and mental health, sort of as number one. And they're wary of starting in any medications or putting in any devices that might be adverse to that goal. Particular concerns that are cited or are avoidance of relapse triggers. So that could be things like needles or injections. So that's Depo-Provera. Scars, which is you can get a little scar from the implant, which is Nexplanon. Risk of complications and infections from inserted devices. So for example, IUDs do carry a small risk of infection. They hear that, and some women with a history of endocarditis worry that infection will go to their heart. And so these are things that, that are very concerning to them. And then weight gain is often cited as a risk for relapse as well. So Depo-Provera is one that mainly affects that. Some also worry that adding systemic medications will interfere with psychiatric medications that are keeping their mental health stable. And they also place particular value in preventing sexually transmitted infections. And so sometimes prefer to only use condoms, which are dual use and also cheap. Patients in this population also have significant barriers to accessing family planning care. There can be challenges in insurance coverage, potentially only covering certain contraceptives or only certain providers. They often will have transportation issues, so getting to a GYN clinic, or if they want a certain device, sometimes you need more than one visit. And because it can be challenging to get to these clinics, sometimes these patients also may not have accurate knowledge about different types of contraceptives, so they won't know exactly what might be something that meets their goals. Patients sometimes also report unexpected social barriers that we may not think about. So particularly patients that are living in communal environments like residential recovery or shelters may not have ready access to a bathroom, for example. And so don't want a contraceptive option that makes them bleed frequently, even if it's not heavy, because they can't actually access those spaces for feminine hygiene. Additionally, they may not have private refrigerators, so they can't use any method that might need to be refrigerated, like, for example, a vaginal ring. Sorry. Finally, there's significant stigma surrounding pregnancy and contraception for patients with OUD. Society feels that people with opioid use disorder should not be pregnant or have children. For this reason, there's a significant risk of contraceptive coercion, particularly for long-acting reversible contraceptives. We call them LARC, which are the IUDs and Nexplanon. They're highly effective, but that doesn't mean that they'll meet the patient's reproductive goals. So this is just one example of this type of coercion. Project Prevention is an organization that pays patients with substance use disorders $400 to get a LARC, so an implanted device, or sterilization. And this is a response by Olson and colleagues that highlights that women's drug use should not automatically be associated with an inability to make informed healthcare choices or to care for children. Our evidence suggests that women who use drugs do not need to be paid to limit or end their fertility. Like they can seek that out if we remove those barriers. And programs that aim to reduce barriers to obtaining free, non-discriminating reproductive advice and preventing and parenting assistance would be better utilize women's agency to improve their own reproductive health. On the other end of the spectrum, patients in this population can also be at risk for reproductive coercion from partners. So it's always really important to get the patient's wishes and goals separate from partners when needed. So with so many barriers to reproductive care in this population, it's imperative that we try to remove these barriers as best we can. And these are some ways that patients have actually suggested that we as healthcare providers can help them gain access. They say we need to reach women with unmet need, provide free or affordable contraception, maximize service accessibility, and clients say that they do prefer on-site family planning services, and this is talking about places like OTPs. Provide patient-centered care, so what the patient needs and wants and not what providers think they need. Employ willing, qualified contraceptive providers, and then utilizing peer educators who've been there and who understand where the patients are coming from. Okay, so show of hands, how many people talk to their clients about contraception? And how many people have been asked about contraception or termination or reproductive goals for patients? Right. And then how many people talk to their clients about sexual history, sexual exploitation, and high-risk sexual activity? That's usually a big one, right? Because that's a big thing, you know, that's common in this population. All right. So historically, so I'm going to talk now about contraception counseling and how this can be effectively employed in this population. Historically, we've done contraceptive counseling in something called a tiered efficacy model, whereby basically we started by saying, LARCs are great. Don't you want one? Because they're very effective. They stay in your body. You don't have to remember them every day. That's the implants, IUD, and sterilizations. And then subsequently, we would go down the line and say, these are the other options. They're not quite as good, right? And we thought that this was great because then patients would know how great these highly effective models were because we're trying to prevent pregnancy. But it's become clear that this isn't the best way to provide information on contraception to patients because it doesn't tailor counseling to the patient's values and goals. And I'm not just talking about patients with OUD, really the whole family planning community has gotten away from this as a way of counseling. We will use this graphic just to talk about some contraception options later, but not because it's the way to counsel. So instead, what we want to try to do is what I'm sure a lot of you guys do really every single day, which is shared decision making, right? There are two experts in the room. The patients bring their lived experience, values, and goals, and we bring our knowledge of contraception and our personal biases and goals, which usually includes effectively preventing pregnancy. The important thing is that the patient's values and goals are at the center of the conversation and the decision making, and that we provide patients information to help them make the best choice for them. And so the way that I usually start this conversation with patients is, what are your goals? Do you want to get pregnant? Do you not want to get pregnant? And what is important to you about contraception? And talking about what they have used before, because that's the experience they're bringing from their past. And then offer to give information about any other options or even the options they've tried before so that they can make that sort of informed decision about what's best for them. And as you saw in my case in the beginning, what was best for my patient in that case was condoms and natural family planning, which is nowhere near, right, the most efficacious at all. But that was best for her. And she felt heard. She felt like she was doing what was best for her. And that's what's most important. So how can you guys do this at your OTPs? And why is it important? So as we all know, patients with substance use disorders and opioid use disorder really do tend to have a deeply seated distrust of the healthcare system. So when they gain this trust in a provider or in a peer supporter, it's really a great place to start this conversation because they trust you and they're willing to listen to your advice, but also share with you their goals, values, and fears. There are several ways that addiction treatment services have tried to do this, and I'll go through a few of these here. So the first one is integration and co-location of SUD treatment and contraception, which is what patients or clients identify as something that they find would be beneficial. And it doesn't always work, but sometimes it does. So the first study here was in Baltimore in 2011, which was a combination of an SUD treatment program and a perinatal care clinic. So this was OBGYNs taking care of patients, and they had a qualified contraceptive care provider there. They did 6-week group education model and individual counseling. They had all methods at no cost and all available on site. They saw 700 women and 68% received a method. 47% requested a most effective method, so that's high tier, and then 32% received them, which is huge because we see in this population for LARC uptake really less than 10% on average. With excellent counseling, it's something that worked in this case. The second study from New Zealand in 2020, this was actually at an OTP where they were offering a contraception clinic. So a contraceptive provider that would come to the clinic and would have appointment times to come and get counseling and potentially get a method. In this case, they did not have LARCs on site. They would have to go across the street. And this was a little bit less successful, where they screened for people who were of reproductive capacity who did not want to get pregnant. 23 people were eligible, but only 2 attended and only 1 got a LARC. So, what I take from this is that potentially co-location integration doesn't remove all barriers, right? So, if this clinic was in the afternoon, they were dosing in the mornings, and they need to come back. This is a new provider. It's not the same person you're talking to. So it's not the be all end all necessarily, but certainly something that can work. Counseling, though, I think is a really interesting thing and something that I think can be really beneficial. So this is one study that looked at provider counseling at an OTP. They called it, it was the Sex and Female Empowerment SAFE program, which was a contraception counseling program based in motivational interviewing, which you guys probably do all the time, right? So it was meant to try to resolve ambivalence about pregnancy planning. They did 1-hour sessions in the SUD treatment setting and had escort and transportation to local health departments for contraception. And here what we saw was that compared to usual care, this intervention showed significantly higher patient satisfaction, likelihood to go to a consultation appointment, and receipt of LARC than just sending them to a gynecologist. So this was really effective. Another super interesting one is actually peer counseling about contraceptives. So in this case, it's called SHINE, Sexual Health Initiative, Navigation and Empowerment. It was a peer navigator style intervention where peer navigators met with participants twice to work through a pamphlet about contraceptive options, help them develop a plan, and then referred them to local family planning providers. And in this model, the majority of participants thought it gave them accurate new information, that their peer navigator worked with them, helped them achieve their goals, and reviewed important topics. They felt it was very helpful that the peer navigator had lived experience and could understand them. And in this case, significantly more patients in the SHINE group had a family planning visit in 3 and 6 months. And although it wasn't statistically significant, relatively more patients in the SHINE group received a LARC than the control. So these studies highlight the benefit of reproductive counseling from a trusted source in the addiction treatment setting. And then it all comes back always to harm reduction, right? Harm reduction, harm reduction, harm reduction. And contraception, I would argue, and preventing unplanned pregnancy should be a form of harm reduction, and it really fits in well. Just as we try to prevent infections with needle use or sexual assault, we should also be aiming to prevent undesired pregnancies. Contraception is a part of this, but this is also a reminder that there are multiple options for emergency contraception, as seen here. And I wanted to highlight our Western Mass Harm Reduction Agency, Tapestry, which provides all of these services and even more. So if you guys want to get more education, these are just some examples. So there's some self-paced training from UCSF. This is Boston University, has some training on a patient-centered approach to contraceptive counseling. Bedsider.org is an amazing, amazing, amazing resource for patients as well as providers. This is the patient-facing setting, but it's like you could go through it as a provider and learn a lot as well. And then I forgot to put on here, but I should have, what we use to know if contraceptives are safe for patients with particular medical conditions is what's called the U.S. Medical Eligibility Criteria, USMEC. They have an app, they have a website, they just updated everything. And so that's another great resource as well. All right. And then collaboration, right? It seems like counseling is a really important thing, but collaboration is always important to have someone there if you need them. So we have a great collaboration with PHN where if you have a pregnant person who desires to continue their pregnancy, they come to me. If they desire to terminate, then we have a family planning specialist that they get set up with. And then our clinic has a really close connection with them for anything like contraception. All right.
All right. I have a question. Also an audience participation. Who's intimidated right now? Wow. So how do we start going about contraception? With a corny joke. You saw that was a rocket? I've lost you all. So how do I start contraception? It's not something that is out of bounds. As we get more freedom, depending upon your site, so particularly my site as a large national organization, I'm not really permitted to do any other prescriptive medications other than MOUD right now. However, if I was able to, and some of you are in spaces where you can, this is how you start contraception. You inquire, you get that somebody wishes to start contraception, check a pregnancy test. How hard is that? Is that something that we all do when a woman gets inducted into an OTP? I hope so. Multiple studies have actually proven that there's actually no harm when there is accidental exogenous hormone that is given to a developing fetus. You inquire after that pregnancy test that's negative for their LMP so that you can see, could they be in a window of about 2 weeks where they might be pregnant, but that their urine HCG hasn't risen to the point that it'll turn that test positive. Check for their last episode of unprotected intercourse, same kind of an idea. You would actually, and this is kind of an important one because many people will just say, well, we just used a pull-out. So it's important to let them know that patient what exactly the efficacy of preventing pregnancy is for that, which is after 1 year of use, typically 20% of women that use that will become pregnant, and 4% if they do it perfectly, which I don't know how you do it perfect, but 4% if they're perfect will have a pregnancy within a year. All right, so now I've got a pregnancy test that's negative, and I know that this person is not at risk for being pregnant at this moment, or as best I can tell. So what actually could I do in my OTP to help them with contraception? Well, barrier methods that we've already talked about. Spermicide, internal, external condoms, diaphragm, and sponge. Essentially, the failure rates on spermicide, diaphragm, and sponge, I don't remember the last time I heard somebody ask for any of those preferentially. So realistically, what we're talking about here are the condoms. So those are still fairly effective, and just kind of going through with everybody hopefully knows how to take care of that at this point. But going through with them is helpful if they are not really knowing what to do. So that's something that you probably can all do. Progestin-only methods. Again, all we have is a pregnancy test right now. We could give progesterone-only contraception. It could be oral, which based on the physiology of those pills, it's actually pretty important that they take it at the same time every day, like within an hour, or the efficacy on it starts to really drop. The failure rates, depending on exactly which progesterone is in the medication that you're talking about, for perfect use for 12 months is about 1.8 to 5.5%. So way better than 20%, way better than 70%. Not ideal. Injectable is another method. So the Depo-Provera shot, that Megan was talking about earlier. It's every 3 months. It's important to get it on time every 3 months so that the serum levels of the progesterone don't start to fade and expose them to an ovulation. But that is a fairly effective way. A fulsome discussion about all of the benefits, risks, contraindications, adverse effects, and everything else, I'm going to leave for you to when you've decided at your OTP which methods that you might be interested in having around. But this is an important one to talk about right now. Has anyone heard of Opill before? Opill is an over-the-counter progesterone contraceptive. So you could walk into CVS, find this on the counter, and have your patients started. So we've reached a point now where we certainly can provide more options, and we can empower people more to do better at preventing unplanned pregnancies. So now what else? What else can I do? You're stoked. I'm happy to see it. You want to make sure that they're not hypertensive. Check a blood pressure, which you did at their women's intake. You can check it again before if she's been there a while and you haven't got to your annual again to make sure that she's not hypertensive. No cardiovascular disease risk factors, no smoking over age 35, no migraine with aura, no history of venous thromboemboli. Now you can get into the estrogen containing foods. And there are lots of different ways to do this with patches, rings, pills. These all have basically the same typical use and perfect use failure rates, i.e. pregnancy rates. But there's just a lot of ways to go about this. Other options, which I'll breeze past kind of because I know that Megan talked a lot about these, would be IUDs and implants. These are highly effective, the long-acting reversible methods. Interestingly, just so that you are updated as we are all now, the levonorgestrel containing IUDs used to be that they could be for 3 to 5 years. Now you're talking about 3 to 8 years. The copper IUD is probably efficacious and safe based on newer data up to 12 years. And the Nexplanon implant that we used to be able to leave for 3 years is now efficacious up to 5. All of the FDA data is not fully approved for those yet, but it sounds as though our OBGYN colleagues practice that way right now. So I think you would be perfectly fine in recommending that or advising your patients of those dates. This is a huge graph that you could take a look at more later, but the important piece of this, functionally, is this. It's all well and good for us to start somebody on a method of contraception. The point isn't to get them 1 or 2 months of protection, it's to get them protection for as long as they want. So now, what is the percentage of women that are continuing use of that contraceptive method at 1 year? And so you can sort of step through these, but you'll probably appreciate that the highly effective methods are the ones at the bottom, and your continuation rate is, at least above 75% here. Generally speaking, the methods that are not sort of a daily use or a use per event are usually tolerated and accepted better and continued more often. So that's kind of the yin and the yang of this whole discussion. So an interesting study from Melbstad was talking about contraceptive knowledge challenges, and they took a look at a sample of MOUD patients as well as primary care patients. I'm pretty sure she's in the So this was the cohort that they grabbed. It was important to note, for me at least, they did a good job at making sure that their questionnaire that they used, a contraceptive knowledge assessment, was very appropriate in that they kept it at the 5th to 6th grade Flesch-Kincaid level. Because you've heard us talking, it can get very verbose here when you talk about these things. It's unclear about what the clinical importance of the significant difference between the MOUD patients and the primary care patients, what that actually was. So yes, there's a significant difference there, but what's the clinical difference between scores that they got? We're not really sure. It's interesting. I mean, men have less knowledge about contraception than women. I'm just surprised to hear that in this room, but that's actually an important teaching point because it means that we should be talking about contraception with every single person that comes through the door.
Okay. And then, we had a lot of raised hands for people who've been asked about contraception and pregnancy termination. It will happen to you that if one of your patients will come to you saying she's pregnant and she doesn't want to be. So abortion care is healthcare. It's something that's important. Everybody knows about it and is able to counsel in a non-judgmental way. I tried not to watch the debate. The reality in this country is that there are states where women are bleeding out in parking lots because we can't do a termination for a baby with beating heart. So we are lucky in Massachusetts that we have the laws to protect us, and we are protecting women every day as best we can. So Massachusetts law, there's no waiting period for pregnancy termination. Parental consent is needed under age 16, which is probably not the patients that you guys are seeing. They can get a judicial bypass, which is actually fairly simple, and the family planning folks do this often. It is banned after 24 weeks after for fertilization, unless to preserve the physical or mental health of the pregnant person or for fatal fetal anomalies. The important things here is if a patient comes to you or a client comes to you and says, I'm pregnant, I don't want this now, is that because of the anovulation, the oligo ovulation, and the lack of regular periods, it's not uncommon for us to see this population with pregnancies farther along than we expect. And so if they tell you that it's important to get them referred to an appropriate provider as soon as possible to get an ultrasound, know how far along they are, and so that they can get the appropriate care in a timely manner. And if a pregnancy if they're ambivalent about the pregnancy, it's also important to get to them to someone who knows about how pregnancy goes on something like MOUD, so that they can talk really knowledgeably about the risks and benefits of pregnancy versus not, and give them a good sort of all-around options discussion. So options counseling, how does this go? So the important thing about pregnancy options counseling is that this is a non-judgmental environment where you're able to hear the patient's perspective, offer factual information, and allow them to make a decision. This is a very complex and very emotionally heavy decision, no matter the reason for doing it. So this is just a framework from reproductiveaccess.org, and I'll put them up in a minute, that I think really kind of speaks to this. We want to affirm the complexity in reproductive decision-making and the many ways to build and support families with dignity, right? We want to create an open, inclusive, and non-judgmental environment where the patient feels safe to ask questions, understands your willingness to discuss all the options. There's not just pregnancy and abortion, there's also adoption, right? There's multiple options, and trusts you for accurate information and care. We want to validate and normalize multiple complex and varied feelings about pregnancy, like certainty, shame, disappointment, shock, guilt, and regret. Some patients may come to a decision quickly, while others may not. We want to actively listen to the patient, offer silence for the patient to process and share, open-ended questions, and be open to, interested in, and curious about the patient's process and feelings. So we want to learn from the patient, which is what we really should be doing every day. And then this is really our goal, beyond just being there, being non-judgmental, and letting them use us as a sounding board. We can clarify the facts. We think you're about 20 weeks pregnant. It's legal to this point, and sort of where they can go from here, those sorts of things. And then at the end, and this is always the end of my discussion with all of these patients, I will support you and I will be here for you no matter what you choose. And they always say thank you, and sometimes cry. Because this is really, really, really hard, and they expect people to judge them at every turn, particularly in this population. So already they feel stigmatized and they're asking for an abortion. This is really hard, and you guys might get those questions. This is the same website. They actually have a PowerPoint that kind of goes through helping people kind of work through options counseling, what the options are, how to do this counseling, and how to make patients feel comfortable. Okay. Planned Parenthood. So Planned Parenthood of Massachusetts is amazing. Their website is really comprehensive. If you ever have a patient coming to you saying, hey, I have a pregnancy, I don't know what to do, Planned Parenthood is a good first place to go. It's awesome if you also have sort of referral bases in hospitals and things like that, but Planned Parenthood can probably do a lot more than you might think. Depending on the site, they can do in-clinic procedures up to 20 weeks and 6 days. They can do in-clinic medication abortions up to 11 weeks of pregnancy, and they can even do telehealth for abortion pills. This is a QR to their website there. And then there's a lot of other ways to access timely abortion care in Massachusetts. This is the DPH website where you can find an abortion provider, get help paying for an abortion. And then this is a connection to the hotline. Even Bedsider, my most favorite website. This is national, so you can find abortion providers anywhere. Reproductive Equity Now helps with getting your abortion paid for. And then this at the bottom is the mass abortion hotline. Hi, I have a patient, she's this many weeks, and they will help her get to where she needs to go. So take home points. So patients with OUD face unique social and physiological barriers to preventing unintended pregnancy. And in addiction treatment, all you guys are such a reachable moment. Your clients trust you. They know who you are. They're going to come to you with their problems, and you have the ability to make a difference in their lives and help them reach their goals. The familiar tools we use every day can help patients and clients to identify reproductive goals and allow them to have control over reproductive timing. So the things we talked about were shared decision-making, motivational interviewing, peer counseling and coaching, as well as harm reduction. And it's important to identify institutions that can assist you in comprehensive family planning services. Once you have a patient in a place where, yes, I want to have a plan and this is what the plan is, make sure you know where you can send them to help bring that plan into action. And finally, knowledge is power for you as well as your patient, and you can really help your patients feel empowered to control their reproductive timing. And then we will finish, maybe, with a quote from Margaret Sanger: "No woman can call herself free who does not control her own body." If anyone has any.
Kristen, I know I asked a lot of questions, but can you do, I have a number of patients who, I take care of a lot of pregnant women, even though I'm an internist in the OTP. And one of the things that happens a lot is that they do have unintended pregnancies, and then they, say that they're going to terminate, and then it just doesn't happen. And then they say, and I do ask them about contraception, and then they say, oh, I am definitely going to get my tubes tied, or I'm definitely going to do this before I leave the hospital. And then I see them postpartum and they haven't, or they still waffle. Or can you give just a really quick overview to a non-OBGYN, non-family medicine person of what you can do immediately postpartum in the hospital after various types of birth?
Yes. So it does depend a little bit on your hospital, although I think in Massachusetts in particular, there's a big push for immediate postpartum contraception. So at Bay State, we have the ability for so it also depends on insurance. Luckily, this population largely is covered by MassHealth, which will cover in-hospital insertion of IUDs immediately after the placenta, as well as LARC, so the Nexplanon in the hospital as well. We can do so during a C-section, we can tie tubes. I don't know how interested you are in this, but so now we don't really tie tubes most of the time anymore. We actually remove both tubes because it's more effective, and it also potentially decreases the risk of ovarian cancer. So we can do that at the time of a C-section. We can also do that after a vaginal delivery through an incision about this big. The problem with that is that in most hospitals, those procedures after vaginal deliveries are done in the C-section operating rooms. And so whether they get done is often dependent on how many C-sections there are, how acute the floor is, and it's not ideal. So even our hospital is working really hard to troubleshoot getting women the contraception and sterilization if they want it that they need. The other unfortunate blockade to sterilization is that Mass Health requires paperwork to be signed for sterilization that technically needs to be signed 30 days prior to a procedure. There are a few loopholes in it. The purpose of it is good, right? It's to avoid sterilization if people don't want it, right? To make sure people actually want it, to make sure they understand that it's permanent, that they can't get pregnant again. But in a population that presents late to care often, it's not an uncommon thing for me to see. Yes, the patient didn't get her sterilization, gets pregnant again, comes late to care, can't send her paperwork, and so can't get her sterilization again. And so it's an unfortunate sort of cycle sometimes. So there are unfortunately some barriers to that, but those are the things that can be done.
I'll also add, because when I was practicing, I was in a community hospital and we had to take ours down to the main operating room. So it's an even greater layer of complication fighting against the rest of the surgeries and things. Have we backdated papers before? Can't confirm or deny, but it really becomes a barrier.
And the other thing is, if you have a patient who is on, so it is true that Catholic hospitals will not do sterilizations.
Correct.
So do not send your patient who wants a sterilization to a Catholic hospital. For the obstetric care.
Or yes, or just be aware that that's what you're gonna get.
I was just going to add that arming your patient with that information of, hey, when you go to that prenatal visit, why don't you ask right now to sign that paper? That information is helpful, then they can be activated. I'm Liz Quinn. I'm from Lynn Community Health Center, and I'm a family medicine doctor who practices OB and does addiction medicine. So thank you. You guys are heroes. I'm just so appreciative. I just wanted to call attention. You'd pointed out a few links that people can find, but I just wanted to name, particularly for folks in Eastern Massachusetts, Project Beacon at Boston Medical Center has been a godsend for my patients and their autonomy so many times. And they're really devoted to providing abortion care, even, as late in gestation as is legal, and doing so in a setting where patients who often have a lot of our patients have a lot of medical complexities. They may need sedation. They may need to be in an inpatient setting. And I don't know what it is that they've done to get past other BMC departments' phone tree issues, but like Project Beacon, you call the number, you can do it in the room with the patient, and the patient has a visit the next day, and it's outstanding. So I've seen people who were pursuing prenatal care with me up until, and then they say one day, this is not for me, and we're able to get them in properly. So I just really want to advertise for those of us on the eastern half of the state how effective Project Beacon is.
And I think they probably go a little farther than we do because it's the max of legality. Not all hospitals can do the max of legality because of just training. And so I think places like Project Beacon are where we would be referring to.
I want to thank you both for this and also just for commenting again and again on protecting women's bodily autonomy. And in today's age, we need you to keep talking and everybody in this room to keep supporting. Can you talk about low barrier access to vasectomies, please? And what is Planned Parenthood doing on that?
By the way, that is the safest contraceptive method for a woman to use in the cohort, by the way.
Yeah.
And the most effective.
So that's a really great question. People always ask us when we're going to start doing vasectomies. I don't know about that part of the body. So around us, it's really the urologists that are doing, and there's a lot of barriers around that. There really are. And to my knowledge, I don't think Planned Parenthood is doing vasectomies at this time, although they should. It is an office procedure, and for patients who are looking to do that, so similar to tubal ligation, vasectomies do need to sign the same paperwork. So that is a 30-day barrier. But it is an office procedure, can be done under local anesthesia, but also can be under anesthesia if desired. Oh, and that's one more, sorry, I'm going to clear a little bit, and I apologize, but my family planning colleague also recommended talking about this. So there's a lot of particularly social media talk about pain, particularly with things like IUD insertion. And he actually just did a nice little advertisement, and I think he's doing a webinar talking about sedation for IUDs and other GYN procedures. So at Bay State, we have something called a GYN procedure unit, which our family planning doc heads, and patients can get moderate sedation for IUD insertions readily. I mean, it's 1 day a week, so you have to be available at that time. But just for patients to realize that's an option, that we're not trying to torture people, and that we are willing to work with them for what they feel will be best for them.
Just to emphasize the importance of knowing your ultrasound providers, because Massachusetts is not immune to CPCs, particularly in the rural areas. So, if a patient is saying, "Oh, I know the place down the street where a person in a white coat will give me an ultrasound that says, 'Hi, Mom,' and tells me I'm 30 weeks along when they might actually be 12. Think about who you're referring to."
My advice on that point would actually be to make sure that you are, so number one, make sure that you know who your allied OBGYN practice is, OTPs, because I'm pretty sure we all have to have one. So you have an OBGYN practice that you have a relationship already in an OTP. So make sure you know who they are and maybe reach out to those OBGYNs and get some backlines and some ways to be able to contact so that you can get better care with them. But ask for those records. Ask for those records, because you'll see on there, and your OBGYN provider also can help to decode those if need be, to make sure that you can understand when you see that report. But get that record from that provider so that you can be certain that they did it and that they have an official due date on there, so that you can appropriately, sort of figure out when you need to see the patient back, how often you need to do visits with them, and sort of triage other things that may come around it.
And in the event you are seeing someone wanting you to feel their belly, 20 weeks is at the belly button. If it looks like that, then they're pretty strong.
12 at the pubic symphysis, 20 at the belly button.